And the first speaker will be Mrs. Sophie Carlier, and she will speak about early development of a new level 2 autism screening tool, the Autism Discriminative Tool ADT preliminary results. So I would like Mrs. Carlier to ask to begin her lecture, her presentation.
Right, so 15 minutes, okay?
Okay.
So I'm going to present the early development of a new autism screening tool, which I called Autism Discriminative Tool. This is a preliminary study, and we'll have some results comparing autism with other sample profiles like learning disability, language impairment, and mental health problems in children. Okay, so just a bit of theory for those who don't know much about autism screening. You have two types of autism screening disorder, so ASD instruments. Level 1 instruments are for screening the whole population. So as such, they focus on sensitivity, and their aim is to detect people with a possible autistic condition. As such, they're very broad. They do a broad scanning of the children, and as such, they embrace many children who don't have the condition. The most common autism tool is the MChat. I guess you would know that. We also have level 2 screening instruments. They aim to screen children identified as at risk of having autism. I mean children who scored positive on the first level, or children who have a brother and a sister with an autistic condition. Those instruments focus on specificity, they're more detailed. They want to distinguish people with possible autism and people with other developmental disorders. So level 1 screening tools are supposed to be used with primary care providers. I mean general practitioners or pediatricians. All those people should do a routine developmental surveillance, which doesn't really happen, but that's what their body says. Okay. If the child missed to reach some specific milestones, then he should be screened by specific tool. If the child failed the screening test, he should be referred to a child specialist, namely a neurologist or psychiatrist, where he should undertake a second autism screening, where the name Autism Screening Tool of second level. And if he fails again, he's supposed to end up in a clinic, in a kind of clinic where I am working, which is a tertiary specialized autism clinic. Okay. And there he should undergo multidisciplinary assessment. So that's what the literature says, but we just noticed no one does that. So we do have a problem. As some university hospitals specialized in autism, we don't have the first two levels, the first two steps, and we end up with many children to screen. And that's a real problem for us. I'll talk about that. So I'm working in a Child's University Hospital in Brussels, and we have a small unity called Autism Reference Center. The issue we have is that children come quite late to us. Second problem, there are many inadequate referrals. So these children come to us, no one screened there before, and we just end up doing the screening instead of specialized autism assessment, so we're wasting much time for everyone. Late referral, we know that mean age for autism spectrum disorder is about 53 months in the USA, and it goes up to 69 to 75 months in Belgium, depends which part of Belgium, which is obviously quite late. Why do we have inadequate referral? In our center, we have up to 14% of children who should not be sent to a center because they're not at risk at all. For example, they would have no stereotyped or rigid behavior. Why these two problems? Because there are no very good awareness of autism screening tool amongst professionals. You can see here two studies, one from the USA. In the USA, doctors are obliged to screen for autism. That's a legal obligation. And yet when we ask them, only 8% of GPs do so. So that's a problem. My colleague and I, last year, well, 2 years ago now, phoned about 200 doctors, 100 GPs, 100 pediatricians, and none of them were aware of autism screening tool. They couldn't name nothing. They just say, well, it's not my problem, or I don't see autistic children, but obviously they do see them. They have toothache, headache, like any other children. Also, existing tools have weak psychometric properties. For example, they have a high rate of misclassification. I mean, I know it's screening, so you are bound to have misclassification, but a high rate of misclassification, often false positive scoring. You need to buy them. They're very expensive. You need to be trained for them, or they're really long to complete, so it's a problem. Physicians just don't want to use them. So what we wanted to do is to improve professionals' training and make them aware of the screening tools. And also we are trying to create a new screening tool that will address the psychometric weaknesses of other tools, that offers a new approach, among which to include DSM-5 new criteria. So as you might know, in autism now we have those specific diagnosis items which are related to sensory issues. And those are very important in autism for screening and diagnosis, and we don't see them in existing screening tools. So we have included them in order to maybe better identify children who are truly at risk of autism. This would reduce the wait the family have to have an assessment. I mean, in our clinic it's not too bad, it's 3 months. Some parts in Belgium and France it could be up to a year. So what's the point of having to wait 1 year to have your child assessed? I don't know about that. Okay, so the screening tool in itself is a paper questionnaire for now. It's based on direct observation of behavior, either the presence of atypical behavior or the absence of so-called normal behavior and milestones. It's composed of 34 items, so mainly ASD symptoms ranging from mild to severe degree. It's composed of 4 sections, which are socialization, communication, stereotype behavior, and a section I called Other, which include sensory items and symbolic play. I didn't put socialization and communication together as in the DSM-5 because at the time it was easier for me to collect the data and analyze them. So the ADT is a level 2 screening tool, so it should be used by child specialists when a child has a brother or sister with autism or has developmental disabilities, but we still don't know what kind of disability. The targeted population for the tool is 3 to 8 years old, so it's not an early detection tool because there are early detection tools. There's no point of doing what others have done nicely before. And also because we see children who come and are in primary school, so obviously we need to screen those children as well. It's quite quick and easy to use, takes about 5 minutes. No training is required. We hope it's going to have discriminative properties. And that's a new thing. It's based on teacher's observation. I'm not going to speak about the teacher's observation part here, but it's a tool designed for teachers to come and complete observation from clinicians and parents. Because I think, teachers see children every day in different kind of settings, so I think their meaning and the information are really important. So the research process, it's in fact the exploratory study. The aim was to explore the questionnaires' content. I mean, where we write in setting all those items in the questionnaire. We wanted to check the item most frequent in autism and potential discriminators between autistic children and non-autistic children. So it's not a screening tool designed to say it may be mental health issue or language impairment. It's autism versus non-autism. And I'm going also to present a differential profile of all the samples. And we have a prospective study which is now going on, which is the real validation phase of the tool. So the methodology for the first part of the study is as follows. We have nearly 200 children aged 2 to 14 that we saw in our autism clinic for diagnosis. We divided them in 4 groups. autism, which is generic autism, mental retardation, language impairment, and what I call psychoaffective disorder, embracing all sorts of mental health issues. The rating procedure, at this point, we use it as a behavioral repertoire, not as a screening tool. Obviously, if we use the tool as a behavioral repertoire with professionals like us, and it's not good, obviously it won't be a good screener. So we had to do that first step before validation. Inclusion criteria, all children had a definite diagnosis, clear diagnosis, generic autism in the autism sample. We excluded people with epilepsy, a genetic syndrome, as it might affect the clinical pictures. And we excluded children with Asperger's syndrome and pervasive developmental disorder not otherwise specified, because there were quite some discussion about the validity of those clinical entities. And did some results analysis with statistic. So the first result we have is that out of the 34 items in the questionnaire, 23 are strongly correlated with the autism group. This is the first 10 strongest correlation with the autism sample. So you would see in purple, most of the children have socialization problem, and then they don't have much communication problem on our questionnaire. They mainly have the other problem, which were the sensory issues. So when you look at the profile of autistic children, they mainly have socialization problem, then sensory issues, before communication and stereotyped behavior. This is in full plain English. For example, the strongest correlation is item 9. For example, in shared experience, the child does not or rarely bring his toys. Parents would tell us that. It's quite frequent. Another one is lack of eye contact. Obviously, you would know that. And item 28, for example, child would cover his ears in reaction to specific noise. So we could, at this point, maybe think about creating a version with 23 items. But if we do that, we have a problem. I'll tell you what. Just because the most frequent items within the autism group are not necessarily the one who can discriminate between autism and non-autism. It's not because they are frequent that they tell us the child has the highest probability of having autism. So some items are less frequent but very discriminative. On this graph here, you have the comparison between autism and mental retardation, which are the most overlapping condition. You can see that children with autism, over 40% of them do align objects, and you don't see that in mental retardation at all. So we wouldn't have kept that item because it's not that frequent. It's not even 50%, but it's very informative when you want to assess a risk of autism. I'll talk about the other one later on. Sorry. So when you look at global profile, on the questionnaire, you see that clinical groups differ. So in red, you have the autism profile. For example, item 1, it's lack of eye contact. It's rated positive in over 90% of the autistic children. Yeah? Children with mental retardation have a lower score on a questionnaire, but it's quite a similar profile. And you would find some common behavior between autism and mental retardation. Children who have language impairment and psychoaffective disorder are well discriminated on the questionnaire, but they don't score very high. But it's not our aim anyway. So under these experimental conditions, we can see it has discriminative properties on, okay, I have to explain here. Function 1 is related to the autism sample. Function 2 in statistical results is mental retardation. So if you cross two lines horizontally and vertically, you would see that children with autism spectrum disorder are quite well separated on the right, and are even separated from children who have mental retardation in green, although most of the children who have autism in our sample also have mental retardation. Okay. So that's the predictive value for the tool. So out of the 50 54 children, 2 were missed by the tool and classified as having mental retardation or psychoaffective disorder, giving us an estimated sensitivity rate of 0.96 and specificity of 0.98. But obviously, these are really... I finished? It's finished? Okay, I'll go quicker. Okay. Oops. Okay, 2 more slides, because that is very interesting. The items that differentiate children are stereotyped behaviors, so you would see the comparison here. Children with autism have a lot of stereotyped behavior. You don't see them in the other groups, except for flapping, which is quite common in children with mental retardation. So if a child flaps, he either has autism or mental retardation, but nothing else. So, and also in terms of sensory peculiarities, these are the most discriminative behaviors. So you have the rate here. Hypo and hypersensitivity are quite common in autism. It's nearly 60% of rating. Problem with visual information processing and food selection, you really don't see them in all the other samples. So when you look for a child who may be at risk of autism, he has those features. And you can see it here. That's the rating of sensory issues in the autism group compared to the other 3 samples. You don't have it. I have to finish. Okay, so that was the shortcoming of our study on the left. And on the right, we are doing the validation study. Raters are no longer professional. They are the teachers, the one who will use the questionnaire. The questionnaire is used at the beginning of the assessment session, so no one knows the diagnosis. And we'll see whether it's going to have a good future to screen children with autism.
Now, Mrs. Carlier, thank you very much.